For this afternoon and tonight, a significant winter storm, including heavy snow with blowing and freezing snow.
Hello and welcome to the SnowBrains podcast, where it's my job to interview the most interesting people in the snow sports industry and pass their fascinating knowledge on to you, our listeners. I'm your host, Miles Clark. I'm a professional free skier, a mountain guide, an Alaska heli ski guide, a UC Berkeley molecular cell biology graduate, the founder and CEO of SnowBrains, and today was day number 1 of my 25th Northern Hemisphere ski season. I kicked it off today at Snowbird here in Utah, where they surprised us all by opening the tram on only their second day of the season. Low expectations truly are the secret sauce of life. As a passionate outdoor recreationist, you already carry your most powerful safety tool, your phone. AirFlare transforms it into a mountain safety lifeline that helps friends or ski patrol find you fast. The peer-to-peer feature makes it easy to keep track of your group, and AirFlare works even in areas with limited cell service. It stays off until needed, so it won't drain your battery. Go to the AirFlare article on snowbrains.com and download a free AirFlare trial today. AirFlare, emergency rescue locator in your pocket. My guest today is Dr. Kevin Stone, who has become a real friend of the show. Dr. Stone is one of the world's leading orthopedic surgeons and the founder of the Stone Clinic in San Francisco. He's a pioneer in biological knee restoration, a surgeon trusted by Olympic athletes and everyday skiers alike. He's a voice who's been pushing sports medicine for decades. This is Kevin's 3rd time on the podcast, and every time comes on, we walk away smarter, and usually a little more hopeful about the future of knees. Today we're diving into the newest advances in joint repair, what he's seeing on the cutting edge, and what all of us mountain athletes should know if we want our bodies to last. Welcome back to the show, Dr. Stone. It is great having you on again for the 3rd time. I think you're our record first third time person. And you have been one of our most popular guests we've ever had. Listeners always want more. And for anyone new, Dr. Stone is an orthopedic surgeon, founder of the Stone Clinic in San Francisco, and a leader in biologic orthopedics. Every time we've talked, the field has advanced since our last talk. So our last talk was about a year ago. And so today I'd love to talk about new therapy, cartilage regeneration, any fresh insight you have for skiers and snowboarders. And mostly, I think today we're going to try to answer questions from SnowBrains fans that we've got through our social media. So I'm excited about that too. But I guess we'll just start with, and sorry to bombard you here, what has changed in orthopedic sports medicine since our last visit? Any breakthroughs that you're seeing right now in terms of biologics and regenerative therapies?
How many months do you have to talk to me?
That's good, because I was worried you'd be like, not really, it's kind of the same.
No, it's a spectacular time to be both a scientist. Remember, I run 2 roles, both as a scientist and as a physician. So in both spaces, it's an absolutely dramatic time to be involved in orthopedics and musculoskeletal health and the biology of regeneration and longevity and continuing to play forever, as I wrote that book about. It's
Great book.
It's ecstatic to be involved right now because the science is moving forward at the pace of artificial intelligence. And so in the same fun that you're having when you look up anything today, we're having the same excitement when we look at the therapies that are coming out, the effects on patients, the acceleration of healing, the treatment of arthritis. All the spaces that we're deeply involved in are really moving forward.
I love that. So let's get into some of the nitty gritty. You know, I always like to talk about cartilage because of the lack thereof that I have. So there's a longstanding belief that once cartilage is gone, it's gone. Is that still holding true? Is that still going to hold true in the future? Are there any frontiers being broken down with repairing or regenerating cartilage in mountain athletes?
Yes, is the answer. And there are multiple ways to approach cartilage restoration, regeneration, repair, replacement. What you do when you start to investigate it as a patient or as a skier or as a scientist is try to look at the bias of the people you're talking to when you talk to someone about cartilage replacement. Because if they're involved in regrowing cartilage, as we are, you're going to hear lots of science around what's happening in the regrowing of cartilage. If they're involved in just replacing cartilage as a block, you're going to hear a lot about allograft and Oates procedures and other things that we'll talk about later on. If they're involved only in bionic replacement, meaning all they do is a total joint replacement, put metal and plastic in, then you're going to hear, oh, woe is me, you've injured your knee and it's time to replace it. So you really need to know the bias of the surgeon or scientist you're talking to when you ask that big open question, is there anything happening in this field of cartilage replacement? Because there's so much happening in each one of those spaces. And so if we go backwards, our patients who get total knee replacements and partial knee replacements get them robotically now and go back to full sports. We don't limit sports activity anymore. Our patients who get complete cartilage replacement in terms of a meniscus replacement or a plug of articular cartilage, as soon as those tissues are healed, there's really not limitation on return to sport. In the patients who regrow their cartilage, there's more of a delay because, as with all collagen, it takes a year for that tissue to mature. And so a lot of the research is on how do we accelerate that maturation. So tons of stuff to talk about, but I can tell you the short answer to your question is we're ecstatic about the different advances in each one of these spaces.
And this could be an endless question as well, but where do you think we'll be in 10 years? Is real joint regeneration possible within our lifetime? I mean, do you even see limits? But I guess let's specifically say, where do we see ourselves in 5 or 10 years from now?
Yes, I try not to answer that question. And the reason why is that I've been so enlightened and impressed by the advances that have happened in so many spaces, whether, again, as I mentioned, artificial intelligence or whether it's science and biology, that it takes us down new pathways. And those pathways are unexpected. Let's just look back 5 years on stem cells. So 5 years ago, everyone that you knew of was running to Mexico or Caymans or to Germany to get some kind of stem cell injection. And it turns out the science has really evolved from that point of view, where we now realize that everybody, you sitting there, have billions of stem cells within your body. And our job is to mobilize your stem cells rather than injecting a few thousand or a million cells that might just die. So there's a dramatic shift in the whole way we think about stem cells. So much so that I wouldn't have been able to tell you, hey, 5 years from now, this is what we're going to be doing. So I like to think about, hey, what can you do today to maintain yourself, to diminish injury, if you get an injury, to repair it, to maintain the level of excellent and athletic performance that you want to do, and also to do treatments and therapies that don't burn bridges for things that are coming down the line and that you may be a candidate for 5 years from now.
So again, I like to talk about myself. So, and sometimes I think it's good to have something very specific to get more finite answers. So and if you remember a little bit of my history, I had a ACL replacement in 2015, and I ripped off about a square centimeter of cartilage in my femoral condyle on the end of my femur. This is all in the lateral compartment of my left knee. And then I really damaged that meniscus. And since then, I now have worn away my cartilage. And I just got an MRI because I started having knee pain again last year and got to the point, it happened really quick. I went off a little tiny jump and it was like a stab in the knee. I went to get an MRI and it came back. And, they say having no cartilage is sort of a myth. You always, bone on bone is kind of a myth. You always have something. But mine said you have a complete lack of cartilage in that lateral space in my knee. So I'm curious, what about someone like me with an MRI like mine? I have a complete lack of cartilage. What options are there for me cartilage-wise?
So the first thing for your listeners, so that we clarify the language a little bit. So there's two types of cartilage inside the knee joint, per se. There's the articular cartilage, that white shiny surface that covers the bones and all joints. And that's the one that's challenging to regrow and replace. When
Mhm.
you get arthritis, it's wearing that cartilage down to the bone and even damaging the bone underneath and the lining of the joint around it. The meniscus cartilage is that fibrous shock absorber that sits in between the bones. It's a fibrous type of cartilage. And when you tear that or lose it, its function of providing stability, providing shock absorption and lubrication for the joint is lost. And then that shiny white articular cartilage rubs against the other surface and eventually rubs it down to bone on bone.
That's what happened in my case, I believe.
Yeah. So when someone says what you just said about your own knee, the first thing to do is number one, to get a good exam, good history, always good x rays with an MRI,
Mm.
because the x rays are much, much better for joint space and for looking functionally where your joint is worn off. So, for instance, in an MRI, your knee is just sitting in one position and the pictures are taken. In
Mhm.
an x-ray, when you're standing and the x-ray is taken straight forward to back, it shows mostly the anterior part of that femoral condyle, the end of the bone of your thigh bone. When you bend your knee, the joint bends and we can see the space that you have at the backside of the femoral condyle. And those two things can be very variable, meaning you could have worn off all your cartilage on one part of that condyle, but not the other part. And therefore, you might be a candidate for one procedure versus another procedure.
Mhm.
In general, to be a little more specific in general, when you've lost the cartilage down to bone on bone, so the x-ray, not so much the MRI, but the x-ray shows that there's no joint space there, either when you're standing or bending, then it limits our biologic options and we're shifting over to more bionic options.
Mhm.
If, on the other hand, there is joint space, then we can have the conversation. Do we replace your meniscus, regrow your cartilage, or do we do a partial knee replacement for that side of the joint?
And what's exciting is that you've had success in all of those procedures, right? So bionic, if because you mentioned doctors having bias, my guess is your bias is towards the biologic replacements because that does seem like I don't know, it seems like the best pathway when I about it as well. But you've had success in all three of those spaces. Could you talk a little bit about that and maybe even mention athletes that have gone through those procedures and found success moving forward?
Sure. So I'll work backwards just for the fun of it. So the bionic procedures, the partial knee replacements, as you know, many skiers are on your
And that would
call
probably
for.
be me, a
And
partial.
yeah, and they all hear about Lindsey Vonn and the procedure that she had. And that's a robotic partial knee replacement, which is what we've been doing here now for 17 years.
Wow.
For our outpatient, when they have bone on bone, they want to return to sport, the rest of their knees pretty healthy, then we do a partial knee replacement and get them back to full sport. I have patients who've run across the United States on their
Wow.
bilateral partial knee replacements. And so the old days of saying, hey, you can't get back to hard skiing or running or climbing are gone. We really can get you back. Because they're such effective procedures, we now have been using them in younger and younger patients, where in the past I would have pushed the limits on a biologic replacement, regrowing their cartilage and meniscus. Many of my skiers just don't want to wait the 6 months to a year that it takes to recover from a biologic procedure. They see people like Lindsay and others who have done so well, and they choose to go the bionic route. And I fully understand that. In the past, we were much more cautious about doing it, and now we're much less cautious because I very rarely ever see someone fail those or knock them loose or wear them out. I've been doing this now for 30 years. I've had one patient wear out the plastic insert from sport in a partial knee replacement. So we've really
I've got
changed
to
it.
cut you off for 1 second because that is what's so fascinating and terrifying for people like me.
Right.
So you're not seeing the people wear them out. What do we, and I know this is cliche and hard to gauge, but what do we think the lifetime is of these replacements for someone active like me who's backcountry skiing and hiking quite a bit?
So the companies tell us that
Mhm.
in robotic testing in the lab, the plastic insert is a 30-year insert and it can be
30 years.
replaced.
Okay.
So unless you knock the cement loose, the implant should last your lifetime. Now, in the old days, doctors would tell patients with a partial or total knee replacement, rest your knee, bike, swim, don't do impact. We don't want you to wear it out. Well, unfortunately, that caused people to lose more bone and lose more muscle as they aged. And so they had a higher likelihood of failure than if we tell them, listen, we are putting a chip in your body that you must exercise every day. And the more you exercise, the better you are going to do because you'll build bone, you'll build muscle, and these implants should last.
And you're talking about osteoporosis, essentially. People,
Exactly.
they're not doing enough exercise, so their muscles aren't pulling on the tendons and ligaments and everything. And so they're losing bone because of a lack of activity. Continue.
Exactly right. So the more you exercise, the more you're going to build bone, the more you're going to build muscle, the better you are going to do, and the happier you're going to be.
Hmm.
So that's what's happened in the shift in the bionic space. Now, the shift in the biologic space is that we are doing more and more cartilage replacement in not just knee joints, but also in ankle joints too, where we're seeing these arthritic joints where people are told that their sports career is over or they have to wait for a joint replacement later or whatever. And we're finding that we can regrow articular cartilage in spaces where we didn't think we could before. And so, as long as the patient's willing to do the rehab and invest the time, then we're quite aggressive now about offering that as an option. The first stage of this conversation, is, in which I'm sure lots of your listeners will have questions about, are what about all the non-operative ways of stimulating cartilage to heal, keeping the joint healthy and lubricated? And that's a long conversation, which I'm happy to dive into as soon as you're ready.
I'm ready. Yeah, I guess just because of my curiosity, because I think I heard you say that if somebody has a knee replacement, there's a replaceable wear and tear part. Is that correct?
That's correct.
Okay. Instead of having to redo, what do they call it, a revision of that knee,
Right.
which is arguably traumatic surgery, right? It's a major surgery, and you're going to have to chop into the bone a little bit more. Maybe you wouldn't have to do that at all. So the knee replacement would stay, and you just would change the surface. Is that correct?
That is exactly the goal. Now, there are people who don't get to that goal, meaning they either didn't have the joint placed correctly, or they had a biologic reason for failing, or they had an infection or illness or something else that caused that implant to fail earlier. And that's tragic. And so, because the first time is always the best time for anything we do in surgery in general.
Mhm.
So, because it's not a perfect operation, because things can go wrong, we always try to do the least invasive thing with the most options for salvaging it whenever possible. That's why the bias, and my bias, is to always do a biologic procedure and replacement whenever I can, whenever it's the right patient, and then go to the bionic procedure when the biologic is not an option.
Well, let's get into those biologics because, like you said, our users are going to be very interested in not getting surgery.
Right. So here are the ways to keep you out of my office, or certainly out of my operating room.
Let's do it.
So the space is about how do we stimulate healing? So we're in what I call now the anabolic era of sports medicine. So in the past, you tear your meniscus, you get an injury, the doc would take out the tissue, jam cortisone in, shut down the healing, and your joint would degrade.
Well, a trick knee was when they took your meniscus out, right?
Yep,
Yeah.
all of that. So fortunately, that era is ended a while ago, although not everybody's gotten the message. And the message is, listen, we're in this anabolic era. We have these tools that can, number one, put tissues back in, of course, if you need a new tissue. But number two, we can add lubrication and growth factors and stimulate the cells around that joint to go through a healing response. And we can recruit the billions of stem cells that are within your body to the site of injury to help with the healing response. On the good side, these injections now, we call them a cocktail. We have a lot of patients that come in just before ski season saying, hey, doc, I'm not letting you operate on my knee until that cocktail doesn't get me through the ski season.
Hmm.
So on the good news, these are incredibly potent injections. On the bad news, they don't work for everybody. And it's hard to know for sure who it's going to work for. So it's a trial and error a little bit. But in the patients who are super responders to these, will get up to a year or two of relief before they come back in.
And are we talking about PRP, platelet-rich plasma, and similar injections?
Yep. So let's talk about the cocktails.
Hmm.
So the cocktails of anabolic, of stimulating your joint, are PRP, which remember, we take your blood, we spin it, we get the platelets. Within the platelets in your blood are packets of growth factors, and we get those to release into the joint. And they do a number of things, which are they are anti-inflammatory, they're antibiotic, so there's very little chance of infection if it's done sterilely. They're anabolic, they stimulate the lining cells of the joint to produce more lubrication. They're immunomodulatory, meaning they shut down rejection responses. We'll talk about that for birth tissues. And most importantly, they have a paracrine effect, which means they recruit your body's own stem cells to the site of injury to augment that healing response. We can add to that PRP and HA cocktail additional growth factors and cells, and that science is tricky right now. And let me explain the trickiness of it. If you have a wound, if you have a diabetic ulcer on your leg or a wound that's not healing, in the United States, you're allowed to take a birth tissue, a membrane from the amniotic source or Wharton's jelly, and put it onto that healing area that is having difficulty healing and accelerate that healing response. We know that in the birth tissues, there are 60 times the growth factor concentration that exists in your own PRP. And so
Wow.
it's a potent addition to this anabolic injection. Unfortunately, in the United States, the FDA does not currently approve those birth tissues to be applied as an injection in arthritis. And so there's quite a difficult moment in the current regulatory environment of, can your physician apply this to your joint? What forms do you have to sign, recognizing it's outside of FDA approval? And there's a whole brouhaha, as they might say, in this space around the augmentation. But as you're looking out, as you mentioned earlier, what's coming down the line? What's coming down the line is that we're realizing that the fountain of youth is really birth tissues. Nothing's growing faster than the fetus. And our ability to harness that natural regenerative ability is going to make all of our injections better and better and better.
Well, that's fascinating, and I guess coming back to me again. So my history, I started doing PRP, and what was odd was the first time I used it, it didn't do much. The second time I used it, it worked for a year. So now I get 2 of those per year, and I had gotten one in the fall. So let's say a year ago in November, and my knee started hurting in March. And I went and saw a local doctor here in Park City, and I was trying to get up to Alaska a few days after that, but it didn't look good because I was in such pain and had swelling. He encouraged me to get a cortisone shot, which I know there's a lot of controversy around. So I did. I got the cortisone shot. I always have Celebrex pills. And so this is an NSAID, a non-steroidal anti-inflammatory. Probably, I'd like to hear your opinion, probably not too different from ibuprofen, a little bit more specified to arthritis, I believe. So I've gone this sort of anti-inflammatory path. I got the shot. I was able to ski 4 or 5 days later. And then now, it's not very often, but if I do start to feel some pain, or if I know I'm going to have a big day, prophylactically, I might take a Celebrex. My question to you is there still value in me, because this would be the time, basically next week, in getting PRP injections again?
So let me tell you that I like to give good advice based on evidence. And so when a patient asks me, or a friend asks me what to do for a specific thing, what we have done is set up on our website called stoneclinic.com a free, no charge, outside consultation portal.
So I could ask a question
So,
like this.
so that you can not just ask a question like that, you can send in your x-ray and MRI,
Oh, wow.
and then I can get on the phone with you with data in front of me. So
Mhm.
I can look at your data and give you a good, without, clearly the best way to give medical advice is if I can examine you. But at
Mhm.
least I can give you an answer to a question with your x-rays and MRI in front of me and be more likely to be in the ballpark of the right answer for you.
Mhm.
In general, the question you asked, if PRP worked well for you before, it's a good thing with very, very safe profile to use again. Now, let me give you an ethical dilemma on that, though. So I have a lot of patients just like you coming in before ski season saying, "Hey, doc, I'm not letting you touch me till you get that cocktail." It doesn't work. So am I just helping my patient to destroy their knee more? Or am I helping them just to keep playing each season until it's gotten so bad that the PRP doesn't work? So I
Mm-hmm.
don't know the answer to that question. It's a bit of an
Mm-hmm.
ethical dilemma. In general, I try to figure out the maximum number of things to do for my patients and the minimum number of things to do to them. So if I can find ways of improving your fitness, your gait, your mechanics, all your conditioning, your mindset before ski season, that's my first line of intervention with you. My second line, of course, are these injection therapies because there's such minimal impact and such huge benefit. And then the third line is, of course, making an accurate diagnosis and then surgically repairing whatever is wrong.
Is there any hesitation about my age around getting a partial knee replacement? Because I'm 47 years old, and I know most people say you want to wait till you're a bit older so that you don't wear it out.
So the don't wear it out, we've already addressed. You're not going to wear it out with
Mhm.
very little likelihood. The answer to your question is it depends. Are you too far gone for a biologic intervention? If you are, then there's no reason to live in pain and give up the things you love to do. Life's short. You don't know how many decades you're going to get. I don't believe in having people live in pain waiting for something better. So if you've gotten to the point where your knee is getting in the way of your life and all of my non-surgical things aren't helping, or aren't helping enough, then it's better to fix it and go out and play and live life.
Imagine significantly cutting search times when locating guests lost or injured, even in areas with limited cell service. AirFlare Search Tools text out location back technology allows ski patrol teams to quickly pinpoint a guest's phone, respond immediately, and guide them to safety. Already in use at over 30 ski resorts, AirFlare's platform works from dispatch to responder, locating subjects with real-time search coordination. It's easy to deploy, simple to use, and built for patrol. Learn more at airflare.com. Most people I've talked to, I have some friends, including pro skiers and guides who have had their knees replaced, they generally say, I wish I would have done it sooner. And I guess that's why I haven't done it yet, or I'm not moving that direction just yet, I'm still quite functional. I still don't have pain in general. And when it comes, it's usually quite mild and a little bit of swelling, and I can take a Celebrex pill and feel better. And even then, if I didn't take the pill, I'd be fine. Usually just a little bit of rest fixes it. So maybe I'm doing the right thing, maybe not. I think really my problem was maybe in the strategies I used with my surgery 10 years ago. Those maybe could have been done better. We talked about that in a previous podcast. But if you have any other thoughts, please let me know. But I'd love to jump into some of these questions we got from our
Sure.
social media, because I think these are going to really ring true for a lot of our listeners. And I think these are questions that people have in general about the ski and snowboard industry, or ski and snowboard injuries.
Both.
All right. Yeah, exactly. Well, let's go. We'll start with weekend warriors and fundamentals. So this is from Jesse. What do you think is the most common injury among weekend warrior skiers, and why?
So it depends on their level, of course, but probably the most common cause of injury is failure of preparation. And so you're busy, you're at work, you may be going to the gym a lot, but you're not thinking about the sport that you're about to do on the weekend. Because what other sport do you do for 6 hours a day, relatively nonstop? There's almost nothing. I mean, you may go out for long bike rides or really long runs, but there just isn't another competitive sport where you're loading your knee or you're loading your body at speed in dangerous conditions for that many hours a day. And so we think about skiing as just so much fun. We don't even think about how much we're doing it in a day. But really, it makes so much more sense to ramp up and get ready for that level of exercise and that level of loading than just jump right into it. And so the weekend warrior problem is that we're all too busy. We get up there, we snap on our gear and go, where really we know that we should have taken our time and prepared not just our own bodies, but our mind and our gear.
I love that. In previous podcasts, you've talked about really focusing and thinking, and we reflected on how a lot of injuries for everyone, weekend warriors and regular skiers and riders alike, come from a momentary lapse of focus. And, I wasn't really thinking, and that was me last year when I dislocated my shoulder. I just totally turned my brain off and went. Where usually I try to be quite calculated, and that seems to help avoid injury. And I think most people would agree with that. So this is from Agreer. Collagen before or after skiing? And same question for creatine. And do you think timing matters?
So collagen, you're better off eating a steak
Okay, tell me why.
because they're both broken down into their amino acids in your stomach.
Okay.
So I think steak tastes better than powdered collagen, and I'd rather eat the steak. Number one. Number two, creatine. Creatine is a potent supplement. You absorb water, it helps your muscles actually build muscle mass more than most any other supplement, and it has a very, very big safety profile. Some people, however, will have complications from creatine, and whether that's kidney function or cardiac function, because there's a relative overload, creatine has not been universally safe. So you want to think about it as if you're going to supplement with creatine. But in general, of the supplements out there, it has been used very widely and quite effectively.
Does timing matter?
So timing is an interesting question. We always used to say that in the first 30 minutes after a hard exercise, like a cycling or a weight workout, that's when your muscles are most receptive to protein ingestion and using the protein to build muscle. That thinking hasn't been particularly well supported in the science. And so it's still more cult thinking that, we all think it makes sense, but can you really find the data to support that statement? And I'm not so sure that you can.
Is surgery for skier's thumb effective? And what should patients know? And I guess to start, what is skier's thumb?
Yeah. So I don't do hands, but I'll tell you that in your hand, you can tear that ulnar collateral ligament right on the side of your thumb. It used to be called gamecock's thumb too, because you'd break the neck of the bird. And most commonly, when you fall with that outstretched hand in the ski pole if you're using ski pole straps and tear that ligament. You'll very rarely, if ever, find an orthopedic surgeon on a ski hill using ski pole straps. So what happens is we don't use straps so that as we're falling, we let go of the pole and your hand is not in that susceptible position. Now, poles are important if you're in powder and you're in places where if you lose your pole, it's dangerous. But in general, you won't find orthopedic surgeons using ski pole straps.
There's a big movement away from ski pole straps, especially in the backcountry, because they're not good to have if you get caught in an avalanche and a few other situations. So plenty of reasons to not use ski pole straps. So this is from Alfredo. Do torn MCLs truly heal without surgery? And what explains lingering pain years later?
Yeah, so most of the time, MCL, medial collateral ligament, does heal. And the reason it heals is because it's outside of the joint. The ACL is inside the joint, bathed in synovial fluid. The medial collateral ligament and the lateral collateral ligament are outside the joint with robust blood supply. And so if the joint is protected after the injury, then the ligament can heal, the fibers of the ligament can heal back after they tear, they can heal nicely. If the joint is not protected and there's lots of laxity or wiggle in the joint, then the ligament will heal long with scar tissue and the joint won't end up as stable as it otherwise would. And so years down the line, you notice that little bit of instability, the joint's pulling on that tissue that didn't heal quite in the optimal position. And those are the people we see with MCL pain later in life.
So the LCL also has its own blood supply.
Correct. Outside the joint, good healing.
I did not know that. That's good to know. Well, let's jump into a different topic here, overuse injuries and skiing longevity. So for skiers who want to stay on snow into their 60s and 70s, what habits make the biggest difference in long-term joint health?
Good question. So optimizing your weight and your fitness is obviously the first thing right off the bat. We all know that weight that's excessive overloads all joints and makes all kinds of problems that are just avoidable if you can drop the weight. So that's the first thing. Next thing is that, I see really old skiers who have skied for a long, long time. And when I ski with them, I'm always amazed at how smoothly they ski. There's just something about, in their brain, their rhythm going down the hill. And you watch them, they're rhythmical. They really don't stop very often. They get into that mindset that makes them a beautiful skier. And they're skiing in their 80s and sometimes even a little older. And they ski beautifully. And so I think the lesson there is that if you can learn to ski smooth, you can learn to play the sport for a long, long time.
Absolutely. Well, I appreciate that. It makes me think of a skier people might be familiar with, Tom Day, who's in the legendary movie Blizzard of Oz.
Mm-hmm.
And I ski with him once in a while at Palisades Tahoe. And gosh, I don't know, he's got to be in his 60s, almost 70. And he can ski faster than me. And he skis so incredibly smoothly. I'm slamming and bumping and getting bucked backseat, and he just right on top of it, and he just stays so smooth. So there is definitely something to that, and you can probably ski bumps, just ski them smoothly. So let's jump back into some of these social media questions. So this is from Jimmy. Tips for riding with patellar tendon pain. When is it safe and when is it not?
Yeah, so we rarely see patellar tendon ruptures except from trauma. We see patellar tendonitis, where people get inflammation in the patellar tendon, and it's achy and it hurts when you're loading. You're on a chairlift, you're in the ski forward position, or on a snowboard as well. You're just loading that patellar tendon, and you probably haven't loaded it that way all summer long. And when you do an MRI of those patellar tendons, you see that little white streaking within the patellar tendon itself, and usually some torn fibers. And so my personal belief, and this is another surgeon bias here. So my personal belief is that there are no such thing as overuse injuries. The injury starts with damage, meaning you injured that tendon. You tore a little bit of that collagen fiber, whether in your elbow or your patellar tendon or all the other places that people complain of overuse injuries. That little bit of tearing doesn't go down the normal healing pathway that it should go down. And it creates a chronic degenerative area that you then keep loading and keeps producing pain. And that's really what people often call an overuse injury. In my mind, it's an initial injury not recognized and treated to successful outcome on day one.
And that makes a lot of sense. And I think most of us, when we think back, could probably pinpoint something to that. Oh yeah, I remember when I tweaked it in way back, and then I didn't let it heal. And from Jacqueline asks, why does snowboarding aggravate plantar fasciitis, and how can riders manage the pain?
Yeah, so plantar fasciitis can happen to anybody. In snowboarding, of course, in your position on the board, you're rocking forward and back a little bit more than you are in a ski boot. The position is just different. You're using the entire foot to angle the board and lever on that plantar fascia as you come forward on backside or front side to get the board up on its edge. So there's a lot of stress that goes through your plantar fascia when you do that. I will tell you that the advances in plantar fascia treatment are PRP and growth factors, as we discussed earlier, in combination with shockwave therapy. And I was a skeptic for years until I really dove into the literature and have come to believe that shockwave does potentiate the healing therapies that we can give. So almost any time I'm giving a PRP injection these days, I'm augmenting it with a stimulus, which is what a shockwave is, stimulates the tissue to have a more robust healing response. And so in the past, when we treat plantar fasciitis, I'd always warn the patient, hey, this might work. It might be 6 months before you're better. Even a year, we've seen just aggravating as all heck. Now, when we add PRP and shockwave to plantar fascia, we can get people better in a couple of months or less even. It's just a much faster response than we've ever seen before.
Well, it's great to have such a finite treatment for that. So hopefully Jacqueline is listening and can go look into that with her provider. This is a very specific one from Blake, coming back from debilitating ankle tendonitis in both ankles. What are the best exercises to strengthen feet, ankles, and knees for repetitive impact?
Well, that's a tricky question. Ankle, feet, it's a lot of joints there.
Yeah,
I would tell
there's a
you,
lot going on in the ankles.
I would tell you if there's a single exercise that you were condemned to do for the rest of your life to get the most outcome for most of your joints and the entire lower extremity and core, it is a squat. And the reason is that there's nothing that, and by the way, a squat done with really good biomechanics. So if you've never squatted before, grab a trainer or a physical therapist and get instructions so you use good squat form. And even if you've done a lot of squatting in your life, you've been in the gym a lot, just grab somebody else to look at your form and video your form, and you'll be shocked at your body position sometimes. You
Mhm.
think you're doing it just right, and you're loaded with weight on your heels, and you're just balanced, and your shoulders are balanced well, and your back's not bent too far forward. And you'd be surprised how many times your squat isn't quite as ideal as it should. So don't be afraid to grab coaching. But to answer that question, I would tell you a squat's probably your best combination exercise.
I like that. And squats are, I don't know what the right word is, they're just difficult. It is one that we always are maybe not trying to avoid, but trying to minimize. So I like that. Dr. Stone says, get out there and do your squats. All right. So let's see. The next question. Here's a general question. How does telemark skiing compare to alpine or snowboard in terms of stress on the body?
Generally, it depends on how smooth you are. So almost every time you see a good telemarker, they're quite smooth. Just
Hmm.
that balance, that knee flexion, that back ski, really with a lot of knee, hip, ankle flexion motion. You've got to be quite mobile to be a good telemarker, where you can be stiff like me or have an arthritic joint and cheat quite a bit in downhill alpine skiing. And I do
Hmm.
cheat a lot because one of my knees doesn't bend all that well. And I can get away with it and look reasonably good at going down the hill. If you don't have good joint mobility, it's very hard to telemark with any style at all.
Are you willing and able to share some of your knee problems?
Sure, so classic story. Tore my meniscus cartilage playing soccer for Harvard way back when. I
Whoa,
remember
that's
the
so cool. You
move.
played soccer for Harvard.
I
Continue.
remember the move I did and knew I shouldn't do it and did it and got caught by the defensive guy from Brown and just had my meniscus taken out. I admired the doctor who did it, even though he was using techniques that I wished he hadn't used, but they didn't really know better back then. But
Hmm.
watching that and watching that doctor in the training room inspired me to go on to orthopedics. And one of my mentors, a guy named Dick Stedman, who a number of your listeners may remember, said to me one day, "Hey, Kevin, if you could figure out how to replace the meniscus cartilage, you'd make a big contribution to orthopedics." And so that was the project that I started off my first major research program and built the collagen scaffold, collagen meniscus scaffold, and then meniscus allografts. And so I benefited by getting back to sports after my first surgery, then tearing my ACL and Vail again. I remember coming a little too fast over the hill, and I can just remember the moment. And unfortunately, had that built right away with a microfracture procedure, which was his preferred procedure at the time. And what that motivated me to do is to say, hey, look, microfracture might buy me a little time, but it's going to fail. I need a better procedure to regrow cartilage. And that stimulated me to make the articular cartilage paste graft procedure that we developed in 1991 and have been doing for patients ever since, now with a bunch of grants to figure out how to make that work even better. And then later on in life, when all of that failed, I ended up with a partial knee replacement about 10 years ago and elected to do that, even though I knew that the rest of my knee had some arthritis and wouldn't be a perfectly normal knee, but would be good enough to get me back to sports and doing the things I wanted to do, taking the least amount of risk. So just the way I advise my own patients, sometimes you pick the procedure based on the sports you want to do and the risk you want to take, that it can be revised if it fails or if you progress to arthritis around the rest of the knee. So someday in the future, I'll progress to another partial replacement in another part of my knee, most likely. But for now, it's good enough.
Well, I appreciate you sharing that because I just have a gut feeling that I really only enjoy working with surgeons that have gone through these kind of things themselves. And so I know the guy that replaced my ACL, he'd had two ACLs himself. And so I just think that I like that they're skiers, but I like that if they've been through the similar injuries and surgeries themselves, because that relatability just makes it so high, and it just really increases my trust with them, because they also, I think, have good tips on recovery and exercises and all these other things, because there's nothing like a firsthand experience. And I think it's great for you and your patients that you've gone through that, because it really creates a relatability and an understanding that is just not there if the surgeon hasn't been through it. So thank you for sharing that. And then we talked about in one of the podcasts that we've had previously about how I had microfracture surgery too, in that spot on my femur where I was missing the cartilage. And I don't think it did a whole lot considering where I am now. So I should have gone to you back then and done some of these biologic replacements. But c'est la vie. So I am curious too, what do you wish, because we've talked about this, and I think you have a lot of really sound perspective on training and more, but what do you wish all skiers and snowboarders understood about training, about biomechanics and longevity that would make a big difference?
I think we've all learned that mobility is probably more important than strength. That, you can see the strongest skiers in the world in the US ski team and other places, and they still get hurt. And in general, if you can be really mobile, if you can be as flexible as your body will let you be flexible, you're going to do better both in your sport as well as in any recovery you may need to do from any surgical procedure or an injury. So I think there's been a pretty important shift from strengthening to mobility. Not to say strengthening isn't really important, but I think mobility first may be the most important message.
And I think it's fascinating for folks that know that Kelly Starrett worked with you.
Yep.
And you may have helped Kelly Starrett get started in all this because he has really changed my life. I couldn't do a squat. Like if you were going to squat around a campfire, butt to your heels, I couldn't do that after my surgery for, 7-8 years. And I started doing his routines, and now I can do a squat, and I do all kinds of weird things that Kelly Starrett, and it sounds like de facto your program does as well with people that are post-surgery.
We were his first job as a physical therapist here
That's
at
so
Stone
cool.
Clinic. Fun to share ideas and help him launch and do well in CrossFit SF.
No, I think it's really special that and now he wrote that book, the Supple
Yep.
Leopard, and then I forget what his app is called. I want to say it's called TRS, maybe is the acronym. But look into it if you are a skier or rider, because those mobility techniques are very helpful and help me a lot. What also might be one mindset shift about pain or injury that would help the average skier and snowboarder avoid surgery?
The pain's not a good idea. So if you're having pain, your body's telling you an important message that something's not working right. And it's really important to address it. So the idea of playing through pain is not a sensible approach if you want to play forever. So identify the pain, fix the problem. That's my overwhelming message. And a lot of times the fix is much more practical than you might have thought of. So don't be afraid of trying to identify the problem and fix it. Look at all your options and set up a program for you that meets your goals whenever you're fixing any problem. And so if you're talking to a physician about a problem you're having, in general, a good sort of inside tip is that if they don't ask you what your goals are, or they can't identify with you to create a program to get you back to your goals, then maybe you ought to think about somebody more creative or more understanding of what your position is in the world of sport and activity and athletics and work, and help partner with you to get there. And it may be that they don't have the skills, but there's another rehab team that does have the skills. You'd be surprised how many people can approach every one of these problems with some novel techniques that may help you get to where you want to go. So I really feel sad when I see somebody who was told they can't get to where they want to go and then wasn't given a path to get there or some creativity to get there. Now they might fail, they might not be able to get somewhere, but boy, you sure ought to try, and you sure ought to be sure that you've used all the world's technology and advances to get there, or that you can do as much as you can do today and set yourself up for something that might be coming on down the line. In general, we're quite committed to helping people play forever, and we can find a way usually to help them do that.
And could you talk a little bit more about the downstream consequences of pain? Because one of my understandings is that, for example, with my knee pain, it can make it hard to grow muscle tissue. I don't fully understand or remember exactly how that works, but could you talk a little bit about those downstream consequences of pain?
Sure. So pain is a huge inhibitor of muscle formation. Many patients have said to us, well, they've had, this was before Ozempic and peptides, which you can talk about too. They said, I can't lose weight because it hurts my joints, but last doctor told me I had to go lose weight before I could have a surgery. And we've learned that's almost impossible because you can't exercise well, you can't lose weight, you can't build muscle if you're having pain. That the cortisol effect of pain, the stress response, is a potent corticosteroid which inhibits muscle formation. So I would tell you that getting out of pain is the first step towards building any program towards sport.
Absolutely, yeah, and because I'm always curious. I broke my kneecap once and fixed that. That was pretty simple. But then after my second knee surgery, my upper leg never quite grew back to the size it was. Granted, they did use my hamstring, so that's part of it is just missing. But my quadricep too, and so that's something I still work on. If you were going to design the perfect preseason program for recreational skiers, what might be the top 3 pillars of that program?
Doing something every day, try to do something in a group, and try to get a good assessment of where your strengths and weaknesses and your flexibility are, and use that assessment with coaching to get better.
I think the first and third make a lot of sense to us. Why in a group? Why is that helpful?
People do more in a group, and it's more fun, and they repeat it more often. And it's not fun, you're just not going to do it often enough.
And I think the competition doesn't hurt either. I went to F45, which is kind of like CrossFit last night, and
Yeah.
you're kind of looking over at your shoulder. And for my case, it was my wife. I was like, damn it, she's lifting more than me. I got to lift more. And so I think that helps too.
I think you proved the point.
Yeah. Yeah, that's all I've got for you today, Dr. Stone. I really appreciate all your insight. It's fascinating talking with you. I always come out of this with a free consultation, and I usually do something moving forward per our conversation that ends up helping me that ski season. So I personally can't thank you enough. I know that our users really appreciate this, especially the users that sent in questions that you were able to answer so graciously. Do you have anything else here at the end of the show that you'd like to add?
It's my pleasure. You can feel my excitement for this space that we're in, because it's just getting so much better, and we're having better tools to help people with, and the surgeries are working better, the artificial joints are working better. The tools are there to keep people playing. And I just would encourage everyone to not let go of that as your goal, to keep playing, keep the fun of it. Never lose sight of that. And if you're not getting information that's helping you do that, find somebody who's going to help you.
I love that, because I think one of the big things that you do well is give people hope. And there's so many of us that are so addicted to sport and activity that when we see the possibility of that being taken away, our hope also goes away. So speaking with people like you that can give us solutions and real-time solutions that can help us to get to where we want to go really builds hope and gives people something to be excited about and something to live for, honestly. So I thank you and your whole team. Thank you so much, Dr. Stone.
My pleasure.
Thank you so much for listening to the SnowBrains podcast. If you liked this podcast, please share with friends and family, and please be sure to subscribe. To find out more about SnowBrains, please visit us at snowbrains.com. You can also find us on Instagram, X, Facebook, and more. As a passionate outdoor recreationist, you already carry your most powerful safety tool, your phone. AirFlare transforms it into a mountain safety lifeline that helps friends or ski patrol find you fast. The peer-to-peer feature makes it easy to keep track of your group, and AirFlare works even in areas with limited cell service. It stays off until needed, so it won't drain your battery. Go to the AirFlare article on snowbrains.com and download a free AirFlare trial today. AirFlare, emergency rescue locator in your pocket. This episode of the SnowBrains podcast was edited by Liam Abbott, and I'm your host, Miles Clark.